Hi, I'm Dr. Robert Fox, staff neurologist at the Mellon Center for Multiple Sclerosis at the Cleveland Clinic. I would like to share with you some highlights regarding progressive MS that were reported at the ECTRIMS meeting in Barcelona, Spain. The first presentation I'd like to share was the keynote address that was given by Dr. Alan Thompson from London. The keynote address focused on progressive MS, which I think highlights the importance of progressive MS to the MS field right now. Dr. Thompson highlighted several key aspects of progressive MS that I think give good context to where we are now in the field. First, why is progressive MS so important? Because of the worldwide impact of progressive MS on the disease course of MS. The development of secondary progression is the dominant determinant of long-term prognosis. And actually, that long-term prognosis is more dependent upon the development of secondary progression than the disease duration or early relapse frequency or lesions on MRI or things like that. So clearly, it's highly important. One of the challenges is diagnosing progressive MS. How do we figure out when patients are evolving into the progressive stage? Right now, we rely simply on their history, which is not a very reproducible way for us to identify when the patient has transitioned into progressive MS. We also don't know the pathologic mechanisms that underpin progression. What causes progression, and how does it continue over time? Is it directly related to active inflammation, or is it more related to neurodegeneration? We don't really know. Probably less the infiltrative inflammation and some other processes that are at play. How do we define the phenotype of progressive MS? Different people view progressive MS in different ways. The neurologist views it as accumulating disability and a gradual change over time. The imager looks at it as progressive atrophy or change in lesions or other advanced imaging metrics. The pathologist views it as axonal pathology or oligodendrocyte pathology. But the patient sees it as loss of independence, inability to work, or worsening of symptoms. So it's really viewed very differently by different people. We also need to develop better clinical outcomes and biomarkers. How do we measure the progression of MS over time? How do we use MRI and imaging like optical coherence tomography, which is a measure of the retina? Are there serum markers or CSF markers, and how do they relate to clinical outcomes? That's another significant need. And clinical trial design. How do we design accelerated trials so that we can identify therapies very quickly? Dr. Thompson then went on to identify the future opportunities and where we need to go with progressive MS. He identified neuroprotection trials and illustrated phenytoin or Dilantin as a therapy for acute optic neuritis, and there were some initial results that were quite promising in that model. Also looking at repair and remyelination approaches. Changes in lifestyle, smoking, and vascular risk factors seem to have an impact on the disease course. Understanding better how to do rehabilitation and enhancing the plasticity of the brain and the spinal cord are all opportunities for the future. His presentation gave a great opportunity to highlight where the challenges are and where the future opportunities lie for us to make progress in progressive MS. The next presentation I'd like to discuss was given by Dr. Yaldisley, which was focused on how to identify biomarkers for progressive trials, particularly with a focus on imaging metrics of progression. Many people feel that the progressive MS pathology is driven in the spinal cord, and so it seemed to make sense to look at the spinal cord in proof-of-concept clinical trials to identify potential therapies. These investigators evaluated the imaging data set from the INFORMS clinical trial. This was a trial of fingolimod in primary progressive MS. They used both the brain MRI and the cervical cord MRI to estimate the sample size needed for future phase 2 clinical trials. The fingolimod primary progressive trial was negative in that fingolimod did not have a positive benefit on either the clinical or imaging course of primary progressive MS. But the data set still is useful to estimate what sample size might be needed for measuring a potential therapy in a future trial. Using a 50% treatment effect, they looked at the cervical spinal cord and the changes in atrophy of the cervical spinal cord over time. What they found was a rather disappointing result. They needed over 1,000 subjects followed for over 24 months in order to detect a 50% treatment effect of a potentially neuroprotective therapy. In contrast, when they used whole brain atrophy, to power a phase 2 progressive MS trial, they only needed about 180 patients followed for 12 months, or even less, 122 patients followed for 24 months in order to measure the same 50% treatment effect. So although we still feel that the spinal cord is what is driving progressive MS, at least using atrophy of the spinal cord as an outcome metric, it seems that that is not sufficiently dynamic, or in another way, has too much variability for us to use as an outcome metric in progressive MS trials. They also found that progression of brain atrophy correlated better with disability over time than the cervical cord atrophy. So again, although progressive disability may be driven by cervical cord disease, imaging the cervical cord does not seem to be useful or as useful as brain volume, at least imaging the cervical cord as was done in this trial. Let me turn now to 2 clinical trials that showed potential promise. One was evaluating ocrelizumab in primary progressive MS, and this was reported by Dr. Montalban. The investigators reported the results of a phase 3 clinical trial in primary progressive MS called the Oratorios trial. In that trial, 732 patients with primary progressive MS were randomized to either ocrelizumab given every 6 months as 2 infusions, 2 weeks apart, and they were compared to placebo. The primary endpoint was the time to disability progression, confirmed 12 weeks later. And what they found was that treatment with ocrelizumab was associated with a 24% reduction in the risk of confirmed progression of disability. They also found a reduction in the 24-week confirmed disability, the 25-foot walk test, new lesions on MRI, and atrophy progression. So very encouraging results. They found that infusion reactions were seen with ocrelizumab, but were relatively mild, and overall the adverse events, including serious infections, were similar between ocrelizumab and placebo. So this trial shows very encouraging results, and it is certainly one of the few trials that have been positive in progressive MS. That said, there are a couple caveats. This trial limited enrollment to age 55 or younger and patients with 15 or less years of disease duration. Also, a quarter of the patients had gadolinium enhancement on MRI at baseline, indicating a significant proportion with active inflammation. A previous trial with a similar therapy, rituximab, found that the benefit of rituximab in primary progressive MS was restricted only to those who were very young and with active inflammation at baseline, as defined as gadolinium-enhancing lesions. So we await the subgroup analysis of the ocrelizumab trial to see if the benefit seen in the overall group was also more driven by the patients that were younger and had active inflammation compared to those who were a bit older and didn't have active inflammation at baseline. We also don't know how these results apply to patients with disease duration longer than 15 years and those who are over 55, both of which make up a very large proportion of our patients with primary progressive MS. So although this study is encouraging in its slowing of disability progression, additional analyses are needed to see if this benefit was across the broad patient spectrum. Finally, let me share a study of biotin in progressive MS. This was given by Dr. Torba and colleagues, and they reported the extension results of a phase 3 trial of high-dose biotin in progressive MS. In that trial, they evaluated 154 patients with either primary progressive or secondary progressive MS, treated for 12 months with either high-dose biotin or placebo. The idea behind biotin is that it addresses a couple things that may be driving progressive MS. Again, I mentioned in the beginning that we don't really know the pathophysiology of progressive MS, but we do think it's things outside of active infiltrative inflammation. They feel that biotin may address some of the energy metabolism within the ATP cycle, as well as within the oligodendrocytes in fatty acid synthesis. The primary outcome of their trial was EDSS improvement, the expanded disability status measurement, or a 20% improvement in the 25-foot walk. What they found was that in the placebo-treated patients, none of them had a sustained improvement in either 25-foot walk or EDSS. But in the treated patients, there were 13% who had an improvement that was sustained for at least 3 months. In the extension study, patients that continued the high-dose biotin continued to have the sustained improvement in EDSS. This is an encouraging result, although the proportion that showed improvement was quite modest. Nonetheless, those that improved appeared to maintain that improvement beyond 12 months. A second trial is underway, and that will help evaluate this novel direction in addressing the metabolic derangements that may underpin progressive MS. So as you can see, there remains many challenges with progressive MS, but there are some signs of hope as we both identify the specific challenges to address and have identified some potential solutions that may help. Thank you very much for your attention.